see you there. Welcome. I have a patient presentation I'm going to present to you. Let me just feeding them. Now that I have your attention, I'm Eric Garcia. I'm a nurse practitioner student at UTEP, pursuing my acute care adult geriatric practitioner degree. Today I'm going to present to you an 80-year-old male, Caucasian. This patient does have a history of colon cancer. He had a partial hemicolectomy and followed up with treatment with Folfox. The treatment did fail, so he is readmitted with recurrent colon cancer. He also has a history of nausea, vomiting, gastric obstruction, intra-abdominal abscess versus a tumor. We haven't found out yet. Prior to this, he had a biopsy that we did on his colon cancer, which was positive for malignant colon cancer, status post-hemicolectomy. He also had a jejunostomy tube placed, and he has a NG tube to suction for approximately 2 weeks during this stay due to decompressing because he has a stricture. Review of systems are positive for nausea, positive for weakness, vomiting, abdominal pain, fatigue, diarrhea. His med list includes famotidine, heparin. He's on the insulin sliding scale as well as metoprolol, mirtazapine, pantoprazole, lactated ringers due to the decreased oral intake, and PRN pain and nausea medications, which include compazine, aldosterone, and morphine. Nothing by mouth at this time. Physical exam. Most things are pretty normal. He's very lucid, but he does have TPN use. He does have a jejunostomy tube, which he states he is getting relief since placement. He's also lethargic, but like I said, alert and oriented ×3, and he has been experiencing diarrhea. He also has over 10% weight loss in the last 3 months, for obvious reasons that have been stated. Diagnostic studies include the previously mentioned biopsy. We are pending biopsy repeat for this time as the abscess versus tumor appears to have resurfaced. We also did a CT of the abdomen where we discovered this abscess or tumor, and standard labs, CBC, CMP, and mag and phos daily due to his TPN. Differential diagnosis include colon cancer, acute kidney injury from the diarrhea he is experiencing, and a jejunum obstruction or stenosis from the tumor. Management includes the jejunostomy tube, which is also starting to get feedings. They are trickle feedings as he is not tolerating well, but the diarrhea is new onset at this time, so we will hopefully be able to advance soon. He is also on TPN until he gets to goal, and we are also adjusting that daily depending on how much he is tolerating through the jejunostomy tube. Pain medications, as noted. Oncology is managing the case as well. Palliative care has been consulted. Lactated ringers, and he is on the PPI and H2 blocker as previously mentioned. In summary, the patient does have recurrent colon cancer and is considered terminal per oncology. Once the colon cancer was treated with the hemicolectomy and the Folfox treatment was used, recurrent colon cancer, this was within about 6 months, maybe 9, for the recurrence, is very, very poor prognosis and is considered terminal. We will continue to TPN and advance the tube feeds as previously mentioned, and palliative care was consulted. At this point, he is denying palliative care as well as his wife, but he is considering it for the near future, so we will continue to address that. We are also including pleasure feedings as requested, whatever he wants to eat. He can only eat in small bits due to the nausea and vomiting and the stenosis, but at least he can get some benefit from that and a little help with his mentation. And consult with the family. It is he seems very in tune with his family, so we are making sure we keep them involved throughout the planning.